All right, so we'll go ahead and get started. My name is Melissa Graves. I am a P4 student at St. Louis College of Pharmacy, and I'm going to talk a little bit today about neonatal abstinence syndrome, or NAS. So, what is NAS? It is the effective intrauterine exposure to substances that can cause physical dependence. It's important to know that this is not addiction, which is a behavior related problem. And because these babies are born physically dependent on substances, they can become seriously ill if we abruptly discontinue them. So, the withdrawal is associated with chronic use of substances at or near the time of delivery. And generally, if it's been at least 2 weeks since the last exposure, the neonatal withdrawal is unlikely. And then preterm infants are at a lower risk of withdrawal. This is believed to be due to the developmental immaturity of the CNS. So we'll look at some common substances of abuse. There are some that are associated with NAS and some that are not. So first we'll look at the ones that are not associated with withdrawal. First of them being marijuana, which just has subtle effects on the long-term neurobehavioral outcomes. Cocaine, which can cause some neurobehavioral abnormalities such as irritability, hyperactivity, tremors, and a high-pitched cry in the early postnatal days. But when cocaine is used with opiates, it can actually worsen the symptoms that are associated with opiate withdrawal. And then SSRIs. So the symptoms of SSRI withdrawal will mimic NAS, but it's actually called serotonin discontinuation syndrome, which is the irritability resulting from maternal SSRI use. And this syndrome generally occurs early after birth and is usually self-limiting, resolving in 48 to 72 hours of life, correlating with the drug's excretion. So some substances that are going to be associated with neonatal withdrawal. First, we'll look at the opiates. So we have heroin, which has been associated with fetal death, IUGR, placental insufficiency, preeclampsia, etc. And then methadone maintenance therapy has been associated with a more frequent and more severe neonatal withdrawal compared to drug abuse or illicit drug use. However, we do prefer this during pregnancy as the benefits do outweigh the risks. So the maintenance therapy does help stabilize the mother's lifestyle, reduces risk-taking behaviors, decreases the incidence of preterm birth and IUGR. It's also important that women do not attempt to wean from this therapy during pregnancy, as they often actually require dose increases. And then buprenorphine has been associated with less severe neonatal withdrawal, as well as a decreased overall treatment dose in the infant compared to methadone. And lastly are benzos. These have been associated with low birth weight, and benzo withdrawal typically manifests as hypotonia and hyperventilation. The onset of symptoms for short-acting benzos usually occur at 12 to 24 hours and peak at 72, and your long-acting benzos within 24 to 72 hours, peaking at 5 to 8 days. Benzo withdrawal is usually self-limiting, and there is no specific treatment. So screening for NAS, we can do a urine drug screen in the early post-delivery hours. Can also screen the meconium stool, which will give you a broader picture of the infant's exposure throughout the later stages of pregnancy. You can also use the hair and umbilical cord. So how long after birth will we see the onset of withdrawal? This depends on the substance and the time of last exposure, but we usually see it by day 5. So for heroin, onset typically within 24 hours. For methadone and buprenorphine, usually within 3 to 5 days. And for opioids, cocaine, and methamphetamines, usually in about 24 to 36 hours. And the American Academy of Pediatrics recommends that for your short-acting opiates like Norco and Percocet, that these babies get monitored for 3 to 5 days post-delivery. And then for your longer-acting opiates like your methadone, monitor for 7 days. So what are some symptoms of NAS? Break these down into 3 categories. You have your respiratory, your GI, and your CNS symptoms. So you might see some tachypnea and sneezing, some nasal flaring and stuffiness, poor feeding, regurgitation, or watery diarrhea, as well as an excessive high-pitched cry, sleep disturbance, tremors, and increased tone. And the subclinical symptoms can persist for weeks to months. To score NAS, the most common used tool is going to be the modified Finnegan's Neonatal Abstinence Scoring Tool. Scores of 8 or greater are an indication for pharmacological treatment, and some institutions do have different approaches for interpreting this score, utilizing either an average of 3 scores, 2 of 3 scores to be greater than 8, or 2 consecutive scores of 8 or greater. And then doses are titrated and weaned based on this score as well. There's also the Lipsitz tool, which is also known as the Neonatal Drug Withdrawal Scoring System. This tool is a little bit easier to use, and it does have good sensitivity for identifying clinically important withdrawal. And then this is just a snapshot of what that modified Finnegan tool looks like. So all of our babies who are at risk for NAS should receive non-pharm treatment. And some of these options include swaddling in a light blanket, minimal stimulation, skin-to-skin contact with parents, covering the infant's hands to protect their skin integrity, offering them a pacifier, as well as breastfeeding. So when should we initiate pharmacological treatment? So there are a couple ways to go about this. The AAP guidelines recommend 2 things. Starting that treatment if moderate to severe signs of NAS are present. So this would be seizures, poor weight gain, or elevated values in the NAS scoring system, as well as to prevent severe complications if the infant does not respond to the non-pharm therapy. You can also initiate the pharmacological treatment if the modified Finnegan score is 8 or greater, or utilize the eat, sleep, console method, asking the questions, is the baby feeding normally? Is the baby able to sleep between feedings? And can the baby be consoled or comforted within 10 minutes of crying? And if the answer is yes to these questions, you do not need to administer the pharmacologic therapy. So looking at some of the pharmacological treatment options, first we'll talk about the opiate therapy using morphine or methadone. So morphine for NAS is dosed orally at an initial dose of 0.05 milligrams per kilogram per dose, given every 3 to 4 hours. That dose can be increased by 0.04 milligrams per kilogram per dose if the symptoms are not controlled, with a max dose of 0.2 mg per kg per dose. Once those symptoms are controlled, you want to maintain that control for 48 to 72 hours, and then you can start tapering your dose by 10 to 20% every 2 to 7 days. And with morphine, you want to monitor for respiratory depression. And then for methadone, so this can be given oral or IV with an initial dose of 0.05 to 0.1 mg per kg per dose every 6 hours. And if those symptoms are not controlled, you can increase the dose by 0.05 mg per kg per dose as needed, or increase your frequency to Q4. After symptom control, You can start to taper that dose by 10 to 20% of the therapeutic dose and or extend your dosing interval every 1 to 2 days as tolerated. And with methadone, you want to monitor for a prolonged QT interval. So phenobarb is actually no longer recommended for first-line therapy in NAS, but it does have some use as an adjunctive therapy when the initial treatment is inducing side effects without managing the NAS symptoms. It also has shown to be useful in polydrug abuse. So for NAS, you're gonna utilize a loading dose, which they do say is optional, but recommended at a dose of 16 mg per kg as a single dose, and then follow up with your maintenance dose 12 to 24 hours later. Your maintenance dose is gonna be a 5 mg per kg per day, divided every 12 hours, and you can adjust that dose according to the abstinence scores. Usual doses are 2 to 8 mg per kg per day. After stabilize, you can decrease your dose 20% every other day, or such that your drug concentration decreases by 10 to 20% per day. With phenobarb, it is important to watch for oversedation as well as impaired suck reflex. So for clonidine, it has shown some efficacy in treating NAS, and it also may reduce the duration of pharmacologic therapy. Clonidine does affect the part of the brain that responds to excessive norepi release during withdrawal and has shown to be safer than opiate replacement from a neurodevelopmental standpoint. The guidelines recommend adding clonidine if a majority of the neonate score is due to autonomic symptoms. This is going to be respiratory rate, blood pressure, and sweating. And for your clonidine dosing, 0.5 to 1 micrograms per kilogram per dose, given Q4 if gestational age is 35 weeks or greater, or Q6 if less than 35 weeks. You can increase those doses as tolerated as needed, and after you maintain symptom control, you can begin to wean those doses, but do so carefully and as tolerated to avoid rebound hypertension. Most studies have utilized a 10 to 25% reduction of total daily dose every 24 to 48 hours. And with clonidine, you want to monitor blood pressure and heart rate for potential hypotension and bradycardia. And then buprenorphine is currently under investigation as an alternative treatment for NAS. Its pilot study assessed its use using the sublingual route of administration at an initial dose of 5.3 micrograms per kilogram per dose Q8, and this dosing was based on the birth weight. You can increase that dose in 25% increments based on the targeted NAS scores, and you can also give a rescue dose for inadequate control between the scheduled doses, which is dosed at 50% of the previous dose. Following 2 days of symptom stability, you can start to wean that based on the NAS scores using a 10% daily dose reduction. So some adverse effects of the NAS pharmacologic therapy. Adverse effects of opiates in neonates who were exposed to opiates in utero are uncommon. This is due to tolerance, which is also why they don't often experience respiratory depression unless large doses are given. Occasionally, urinary retention does become our dose-limiting effect. And for monitoring, make sure that you assess the treatment daily and wean the treatment as often as every 48 hours if their scores are stable and less than 8. If you have a neonate with an abstinence score consistently in the 0 to 1 range, or they won't wake up to eat, your neonate may be over-medicated, and it's important to decrease that dose regardless of their wean schedule. Make sure that we are observing the infant for 48 hours prior to discharge and following the completion of their treatment with the replacement opiate to ensure that no rebound withdrawal is going to occur. And lastly, we'll look at breastfeeding. All mothers who are compliant with their sobriety program should be encouraged to breastfeed. There are a lot of potential advantages, and especially to babies suffering from NAS. It decreases their need for pharmacological treatment, as well as a shorter treatment duration is required. Breastfeeding can be soothing and comforting to the infants. And importantly, the amount of methadone in breast milk is less than 3% of the maternal dose, but because it is existent in the breast milk, it does help to ameliorate some of the symptoms of NAS. The breast milk is also more easily digested and can help with feeding intolerance. And a very important counseling point, since methadone is in breast milk, it's important that the mothers know that abrupt discontinuation of breastfeeding can actually lead to infant withdrawal. I have my resources for you there. That concludes my presentations. Thank you so much for listening.